One of the most significant advances in neurology has been the recent introduction of L-DOPA for the treatment of Parkinson's disease. Not only has this drug changed the rather pessimistic attitude of physicians, which has prevailed since James Parkinson first described this condition more than 150 years ago, but it has also focused renewed attention on the diagnosis and management of this unfortunate disease. In a continuing effort to assist the medical profession in print and sound, Roche Scientific Service presents an informal colloquium on the present state of knowledge on the diagnosis and treatment of Parkinson's disease with the kind cooperation of a distinguished panel of experts. Dr. Joseph McClure, Director of Research in Psychiatry at the Montreal General Hospital and Assistant Professor of Psychiatry at McGill University, Dr. Arthur Schwartz, Neurologist, Director of Neurological Research at the Maimonides Hospital in Montreal, and Dr. David Dejong, Internist and Coordinator of the Parkinsonian Project at Queen Mary Veterans Hospital, Montreal. Special mention should be made of Dr. Murphy, the general practitioner on the panel, for in 1960, as Berkmeyer and Hornikewicz were the first to treat Parkinson's disease by injection, Dr. Murphy, with Drs. Surks and Barbeau, quite independently in Canada, were treating Parkinson's disease orally. Moderating the discussion is Dr. McClure.
I would like to start off the discussion by asking Arthur, could you give us a short classification of Parkinsonism?
Sure, Joe. I think it can be classified very, very shortly, as a matter of fact, very briefly. I think there are three main types. The type that followed the encephalitis epidemics of 1919, 21, and 1925, which is known as post-encephalitic Parkinson's disease, usually affecting younger people, coming on fairly quickly after they suffered the encephalitis if they lived through the illness. Then the other two forms come on in older people and are known as atherosclerotic in nature or idiopathic in nature. I think at the present time, most people, most neurologists are beginning to feel that the idiopathic and atherosclerotic Parkinson's are the same disease, really. So it boils down then perhaps to just two forms, the post-encephalitic and the idiopathic types.
As a general practitioner, I would like to ask what are the cardinal signs whereby we may recognize this disease, and talk a little about its prevalence, and perhaps some useful clinical hints whereby the early diagnosis may be established.
Well, to take your second question first, Jerry, I think that there are really only two things about the epidemiology which are of practical interest to anybody who practices medicine. The first is that I think that the disease has been increasing in this century. Now, there has been an article published in the States from Boston by Poskanzer and Schwab claiming that all cases stem from the encephalitis epidemic, and therefore ultimately there will be no Parkinson's disease as these patients die off. But in my studies of this, I have found that all the statistics point to a steady increase in the incidence of new cases, and this increase goes along with the increased numbers of people in most of the Western countries, as well as with the increasing average age of death. And it's essentially a disease which increases as the age of the population increases. The second thing is that I think you can expect that in the older age population, there are probably 1 or 2 or even 3% of patients who have Parkinson's disease as a conservative figure. I found in the hospital, whenever I wanted to see how many cases were not diagnosed, that if you go around the wards, you can find cases by simply asking the nurses if there are anybody with any of the symptoms. And very often they're being treated for something else and not diagnosed as Parkinson's disease. In those days, it didn't matter, of course, because there wasn't a specific treatment. As to signs and symptoms, I think there really is only one clinical problem, and that is the case which is easy to diagnose and the case which is difficult to diagnose. And the ones that are easy to diagnose, particularly the ones with tremor, I just leave it at that for the moment, except to emphasize that the difficult ones, the ones that we all miss, and I think we miss one for every one we diagnose, these ones are more subtle. They don't shake to make themselves known readily to us, but they very often don't know that there's something wrong. And this is the kind of a patient, I think, that the physician in practice wants to learn to look out for, because he can perhaps help him most. This is the kind of patient who sits in your office waiting room or sits in your consulting room, who's perhaps a little abnormally quiet, who doesn't move much when he sits in the chair, who hesitates to speak, who doesn't show any of the normal restlessness, who may not blink. And it may take you a little while to realize, because you're taking a history of some other complaint, that this man has indeed got something else wrong with him.
Well, I'd like to say that from a psychiatric point of view, that patients who present in this way, and especially in the early stages, that these people could be sent to a psychiatrist for what might be thought to be a psychomotor retarded depression. And this is something which I think the psychiatrist is on his mettle to look out for. The other type of patient that Arthur mentioned here was the arteriosclerotic Parkinson. And as a psychiatrist, we may run into a combination of arteriosclerotic psychosis and Parkinsonism in the same patient. I think we have to be aware that in this age group that we could very likely get a combination of these two. Would you say that was...
Yes, I was going to add that to one of the cardinal presenting signs in the minimal Parkinsonian. They may come to a doctor, any doctor, as a case of depression, hoping for psychiatric treatment. I think it's most important to try and recognize the physical signs that can go along with it that will sometimes save the patient a great deal of trouble and time.
As I understand it, the tremor is perhaps one of the earlier signs, and perhaps it is unilateral to begin with and bilateral later. What features am I going to elicit from the patient's family that will let me examine this patient and say, here now I have a high index of suspicion this man may be Parkinsonian?
I think part of the answer to that is, Arthur, you've seen a lot of these patients. Don't you think that the interview with the family often gives you many more clues than the examination does? Very often, if you ask the family, have you noticed any change in your husband in the last couple of years, or a son or daughter about a parent, they'll say, well, Dad slowed up more than I would have thought he was going to. He was always such a youngish sort of a man, and now he seems almost prematurely old. And when you go into what they mean about this, very often the slowing up is really the Parkinson's disease. Do you agree with that, Arthur?
Yes, very definitely. Another thing that can tip it off is a very simple test. Just get a sample of their handwriting and try and get some of their previous handwriting to compare with it. You might pick up a tremulousness of the handwriting that doesn't appear grossly, or certainly the smallness and slowness.
I think another problem that's important, but the practical difficulty in one's office, is that you usually have a fairly small room in which you examine your patients, and they sort of go in and undress, and then you find them on the examining table. But you really want to get them in a larger room, or watch them walk in from the waiting room. If you can just say, well, now, before we go into the examining room, would you mind coming back and just walk up and down for me? And just use your eyes. After all, this is the way Parkinson, he never examined his patients as far as we know from his records. There actually are no physical signs described in his original article except what he could see with his eyes. And I think if you learn to look at people, how loose are they? I think that's a good expression. Are they loose or are they stiff?
What would you tell a patient if you did diagnose Parkinson's disease from the prognostic point of view?
Well, in the old days, we'd just sort of wring our hands and quietly tell the family that we think a slow old man has Parkinson's disease. Now I come at it very frankly and boldly and tell them they have Parkinson's disease. There's a method of control for it. Explain what Parkinson's disease is, why it's important to carry on with the treatment, and generally encourage them that we can get them to a pretty good state of life.
Yes, I agree with that. I think another useful thing to tell them, which everybody does, although we don't mention it, and that is that people always wonder what's causing this disease. And I think it's nice to be able to tell them that, that this isn't due to a stroke, and isn't due to any kind of a tumor, and there's no real paralysis of the muscles. That we have the potential there still left in the nervous system to give you a benefit of therapy, which is now available. It's not as if tissues are permanently destroyed. This is a reversible lesion to a certain extent. Your muscles and nerves and most of your brain are working well. This tends to relieve them somewhat.
While we're on the subject, if you don't mind me interrupting, can you outline some of the problems you used to go through? I know you've been at it a lot longer than I have in treating the Parkinsonians before L-DOPA came along.
Well, of course, the drugs we had were nothing like L-DOPA in their effectiveness, and they were more difficult to use. And then the usual problems were that doctors were so keen to help the patient, they almost inevitably gave the patient too many drugs and then too high a dosage. And it was only the more practiced physician who'd been closer to the problem, who could restrain himself and live with the limitations. The biggest problem for the doctor, I suppose, was the fact that he had to live with the idea that here was a depressing, discouraging disease for which no specific treatment was available. And he had to sort of resist the temptation to over-treat and still be able to go along with the problem of treating an illness he couldn't cure. This is hard for some doctors, more so than for others. Joe, you must have found this problem with doctors want to treat and cure, don't they?
Yes, they sure do. But I'm glad you brought that up, David, because this might, maybe Dr. Murphy could comment a little bit on the earlier days of the development of L-DOPA, and because he was very heavily involved at this stage as a student at McGill University.
I think it's important to state at the beginning that L-DOPA is not a dangerous substance. It's found in nature. It was isolated by Guggenheim from the beans of Vicia fabia, and that it was first synthesized by Casimir Funk, who, by the way, was important in coining the word vitamin. Guggenheim, who isolated it, promptly swallowed 2.5 grams of it and proved that it would induce vomiting.
So it has other uses, Jerry.
Had he saved a little, perhaps we would have been further ahead today. The use of L-DOPA in Parkinson's disease is a rational use. Namely, since it was established that dopamine is present in certain specific parts of brain, the basal ganglia, and is there perhaps for a very specific purpose, and it's not a Cinderella anymore, namely that it's not supplying only noradrenaline and adrenaline, but has a very specific purpose, then the rational treatment is that of replacement of dopamine to those areas where it is deficient. Dopamine itself, unfortunately, is, like many catecholamines, quite inactive by mouth. Also, once in the body, by injection, does not pass the blood-brain barrier. But DOPA, an amino acid formed from phenylalanine and tyrosine, both present in our daily nutrition, passes the blood-brain barrier and presents the receptor sites with dopamine. Thereby, the symptoms of akinesia and perhaps tremor are alleviated. I was fortunate in being given the problem of elucidating the pathways of dopamine metabolism in the experimental animal by Dr. Ted Sirks. And once we had a method for measuring dopamine, we became interested in measuring this in many types of patient. And early in 1960, we were fortunate enough to obtain the cooperation of Dr. Andre Barbeau to provide us with the clinical material and establish that the dopamine levels found in urine of Parkinsonian patients were much less than those found in normals. It's interesting that Funk, who described the vitamin, and we all know what vitamin deficiency diseases are, should be instrumental in isolating the compound and synthesizing it. Because here, this is just a question of replacing dopa or dopamine in the same way that we would replace ascorbic acid in people who were scorbutic or who had scurvy.
This is what makes it so attractive as a therapeutic agent for any doctors to use, isn't it?
This is a more specific therapy for this condition than had been used formerly. Former drugs that were used were anticholinergic. How effective were these drugs?
Oh, I would say they were almost useless, really. Best you could hope for with the common anticholinergics such as Artane, Cogentin, was perhaps a 10% improvement for a short period of time. And then, as David mentioned, as the patient started to deteriorate, the feeling would be to try and give him more and more drug to try and get him better, resulting in all the complications of the anticholinergics. Urinary retention, psychosis, if it got far enough. I think that really the old drugs were probably next to useless, although in conjunction with dopa therapy now I think they have a place. Also, things like simple things like physiotherapy or getting the family to help keep the patient active were probably as valuable as any chemical treatment that we had up to it.
Well, how would one go about treating a Parkinsonian patient now using L-dopa?
Well, I think the first thing is to establish the diagnosis, and I think for the general practitioner who probably sees more patients than anybody else with this disease, that if he has even a suspicion that the patient has Parkinson's disease, I think it's worthwhile, very worthwhile, to have a consultation with the neurologist, even if the patient has to travel to a center. Once that relationship with the consultant neurologist is established and the diagnosis confirmed and treatment recommended, I think that, and in the great majority of cases, the general practitioner should be the one who treats this. He has certain advantages over the neurologist, in my opinion. First of all, he's trained to look at the whole patient, to be a physician. And these people have medical problems as well as other problems. Parkinsonian almost always will get worse when he develops a medical complication. It's an extraordinary thing, but if they get a urinary infection, for example, the symptoms will get worse. And the general practitioner is more likely to look after these things earlier because the consultant won't see them so often. But I think accuracy of diagnosis, awareness of the indications for treatment of L-dopa, the side effects to be expected, and complications, I think the working relationship between the general physician and the neurologist, the physician can require a lot of support this way. But then I think he should be able to treat. Do you agree with this, Jerry?
Yes, and I'd like to say that there are a few traps that the general practitioner can fall into, and that is that there are probably an increasing number of Parkinsonian-like patients who are presenting with Parkinsonian symptoms because of simultaneous drug usage, and I'm referring to the extensive use of Reserpine in the treatment of hypertension. I wonder whether you as a urologist feel that these things can be distinguished clinically to avoid sending you patients that you'll say, stop the Reserpine, his depression will lift, and his Parkinsonian-like symptoms will disappear. What do you think of it?
Yes, I must agree with that. And this is where the general practitioner is most valuable because he knows what drugs the patient is on. For example, if the patient is taking psychiatric drugs, phenothiazines, which will produce the same kind of thing, the general practitioner will know this right away and can often save the patient quite a bit of distress by merely stopping them. Once the symptoms carry on despite the fact that the drugs have been stopped, then I think the general practitioner is in a position to realize that there is something wrong with the patient and probably will realize it far sooner than the neurologist would.
The neuroleptic group of drugs as a whole will produce Parkinson-like syndrome in a very high percentage of patients. And I have found that some of these symptoms that they develop can be terrifying to the patient, and they can be quite frightening to the family. And they can be simply treated by reducing the amount of drug given to the patient, or often by just giving the patient one of the anticholinergic drugs such as Artane or Cogentin.
I think this is a very good basic principle in treating any disease with any drug. If you're in doubt whether the drug is making the patient worse, decrease or stop it. You know, don't you think so?
Oh, absolutely. There's no question. Now, would there be any contraindications for using L-DOPA?
I think there are no absolute contraindications except perhaps a psychotic reaction existing in a patient, and then the DOPA can be almost guaranteed to make it worse. I think one must use L-DOPA with caution, though, in patients with cardiac arrhythmias, certainly in patients with epilepsy, and quite probably in patients who are already showing signs of confusion and perhaps hallucinations, as one would find in the demented old patients.
I think once the diagnosis is established, this is the meat of the problem, isn't it? When with most conditions, and particularly with this one, when do you start? And I personally always say, never mind about the tremor. What are the patient's functions of daily living? Can he tie his own tie and button his own shirt? And can he shave himself without cutting? And can he wash? Can he take a bath? And so on. You go through these functions of daily living. If the patient is showing signs of impairment, I think that's the main indication for treatment, regardless of tremor. And at that point, the thing I would start off by emphasizing is that a low dose to start with and a slow approach with a gradual build-up and frequent visits, close care of the patient every couple of weeks at the beginning. And I begin with, depending on the age of the patient, the older the patient, the more cautious I am, the slower I go. And I begin with 250 milligrams, that's half a 500 milligram tablet as they come presently, 3 times a day with meals, sometimes only twice, sometimes only once. A very small dose in older people, and I'm quite prepared to stop any time when I think that I've done the best I can do without causing any harm. Does that sound too conservative, Arthur?
No, in fact, I tend to be as conservative as that. I will raise the dosage by perhaps half a gram a day every 3 days, and perhaps even more slowly in older patients who could be expected to have more complications, until one reaches the optimum dose. And there I find, again, I'm a little more conservative than Kotzius was in 1967. I find the optimum dose to be around 4 grams per day, whereas Kotzius and later Yar were using dosages up to 6 and 8 grams a day. Found that a little high. What do you think about that, Jerry? Have you been able to go to very high dosages, especially in the early days, without too much trouble?
In the very early days, we started with extremely small doses, and I was perhaps a little surprised that we noticed any effect at all.
Yes.
I think there was a great controversy which raged in the years 1961 or 65 as to whether L-DOPA was any more beneficial than the anticholinergics. Once again, even with the anticholinergics, individualized doses were the keynote. I think Cotius has been brave in using large doses, and I think that if the drug is administered at the right time, small doses can probably be used. DOPA is an extremely reactive chemical and is readily oxidized in the gastrointestinal tract under alkaline conditions, and perhaps the acid media of the stomach is beneficial to the patient. I would wonder why this shouldn't be given, say, prior to meals rather than with meals.